There we go. So, welcome to BayCare Presents. Today, we're going to be talking about the heart. We're going to be talking about the lungs. We have Dr. Claudin Lewis here, and he is a board-certified cardiothoracic surgeon with our BayCare Medical Group, and he is located out at our Winter Havens Hospital. He comes to us with a wealth of knowledge. He completed med school at Howard University, and he had prestigious certificates from Yale and Harvard. He was inducted into the Alpha Omega Honor Society while he was out at Rochester Medical Center. So he has been in a lot of the top areas. He is bringing experience from Birmingham and Women's Hospital at Harvard Medical School, where he did his advanced heart fellowship. See, that's where I saw the heart earlier. And he loves to make a positive impact on his community and establish that strong doctor-patient relationship, which is something we kind of talk about here. You need to create that relationship. You need to have conversation with your doctors. They're there to help you, but you have to share with them. And Dr. Lewis is that. He wants to be that expert there for you, and he wants to partner alongside of you so that he can help you get the best care that you can. And we're going to be talking about lung cancer today, and it's a serious disease that affects the lung. And a lot of people kind of blow it off and, oh, I don't smoke, I don't need this. Or, I smoke too much, I'm already going to have a problem. But there's more to it than that. And I'm really excited to bring Dr. Lewis here today so he can share that information with you. So Dr. Lewis, I am going to click off and turn it over to you. Thank you.
All right. Thank you so much for such an excellent introduction. Can everybody hear me?
Yes, we are good.
Awesome. All right. So again, I'll be talking about lung cancer. We're going beyond the basics. And ultimately, the goal is to improve outcomes in lung cancer surgery. Again, I'm one of the heart surgeons. I'm here in Winter Haven Hospital in the Boston Heart Center. But we also do thoracic surgery, which makes us a cardiothoracic surgeon. I have no disclosures. So lung cancer is a culmination of pathologic cells that form together and form tumors, growths of abnormal cells that typically don't function appropriately and cause major harm to the body. As it pertains to lung cancer, this is within the lung tissues. There are two main categories of lung cancer. There's non-small cell lung cancer, which is a culmination of several cancers, one of which is adenocarcinoma, squamous cell carcinoma, and another cancer that's called large cell. So essentially, they're not small. And then small cell, these small blue cells you'll see under a microscope, which is hence the name, is its own category. And it itself is one type of cancer that really misbehaves. It's 15% of all lung cancers, and the non-small cell happens to be 85% of the others. Lung cancer, for the most part, causes a range of symptoms, but the biggest problem with lung cancer, hence why we're talking today, is that lung cancer, unfortunately, is not picked up early. And when the symptoms are present, usually the advancement of the disease is present as well. Risk factors are several for individuals who are saying to themselves, hey, I don't primarily smoke. Well, air pollution could be an equivalent risk factor in causing exposure. Radiation to the chest, organic chemicals, certain metals could be carcinogens. Certain occupations have higher risk of these things. Being around excessive amounts of diesel exhaust or secondhand smoke as well. Okay. And again, for lung cancer, approximately 70% are diagnosed at an advanced stage. Now, despite how prevalent lung cancer is, it's really important to see some of the frequencies and the rates of all cancers so we can compare them amongst cancers. And as you would see, we're having a lung cancer presentation. So, of course, lung cancer will be number one. It's one of the top 10 cancers of cancer deaths. And when I say one of it, actually is number one. If there is a cancer that causes death, lung cancer is the answer for which cancer is causing the most harm. And a rate of 100,000 people, lung cancer will affect and cause harm and subsequently kill 31 compared to breast cancer in females, prostate cancer in males, or colorectal cancer, pancreatic cancer in all comers. Some of those cancers you can add it up and it's still less frequent than the cancer causing death of lung cancer. As we look a little closer and stratify this amongst males and females, you may say to yourself, well, hey, breast cancer is causing substantial harm to female in regards to death rates. And it's just not true. Lung cancer causes more death in females than breast cancer causes to females. And as you can see, the proportion when it comes to lung cancer as males is even higher. And you may ask yourself, well, why does lung cancer cause this much more harm, male versus female? Well, also, there's a propensity of males to have a larger smoking exposure and carcinogen environmental exposure than female statistically. But lung cancer is causing major problems to both sex, as you can see. One of the biggest discrepancy has been funding for lung cancer. Breast cancer gets on order way more funding than lung cancer. And we are just not sure why. This is true in both the United States, but I wanted to prove that this is also true even outside of the United States in the UK, where the proportions of lung cancer are equally just as problematic. In fact, if you look at all cancer deaths, lung cancer is causing 22%, which is the number one, and breast cancer is at 7.7%. But look at the right in the funding, and those are in the millions, where lung cancer generates $14.16 million of research funding. Breast is almost threefold more funding for one-third less patients. And these proportions are very, very similar in the United States as well. The leading cause of cancer-related death is in the chest, but it's not on it. It's not breast cancer. It's lung cancer, causing annual deaths multiple folds higher. You can add up the next three, and you're still coming close to what lung cancer is causing. Ultimately, the treatments are several fold. There's radiation, there's chemotherapy, there's immunotherapy, there's targeted therapy, and there's surgery. And lung cancer is quite complex. Where in the spectrum are these treatments appropriate, one versus the other, is the reason why you would want to see an expert in order to find out what is the appropriate pathway one should go. But we're here to talk about surgery, and it's important to understand it from an anatomical perspective, or ultimately the anatomy. Just to go back to some basics so we can understand what we're dealing with, what makes the lungs so unique is the anatomy. The lungs have several compartments, and I like to segment those compartments to like states. For instance, if the lungs are United States, the lungs themselves have five states, three on the right, two on the left. So we call those states, so to speak, lobes. Lobes will be the technical terms. But the lobes can be divided even further. So each state has a multitude of cities, and those cities are called segments. The way cancer spreads is it will start in a certain segment within the lobe, and it will travel using highways. And the relation for what highways are lymph nodes, and it will travel from the closest lymph node to lymph nodes closer towards the midline, where near this airway is in the middle. And that is how it spreads. And the word for spread is metastasize. And some of us are familiar with that because metastasis means that you have spread of cancer to a further location compared to where it likely started. So that's ultimately the anatomy. But just to dip a little further in regards to the lymph nodes, which again are the highways, if you have a lung tumor starting in the area on green, either on the right side, which is on the left side of the screen, or the left lung, which is on the right side of the screen, it will then travel to those lymph node stations where it says 10R, 11R, 12R first. Then it will spread towards perhaps 4R or 7, which is more towards the middle. And in the worst case scenario, it will go to the other lung, it will go to the liver, it will go to the adrenal gland, which is a gland that lives on top of the kidneys, or other areas, which could be quite concerning. So it's important to understand, one, you have a cancer. Two, what is the type of cancer? Is it non small cell or small cell, and what is the stage of this cancer. So there's multiple entities in which we need to intervene to participate in understanding the true diagnosis of and concern of this cancer. This picture ultimately shows some of the segments. This is a patient who is laying down, who is, if you can think of loaves of bread, this would be one slice. The heart is towards the front of the chest, which is the top of the screen, and the back is on the bottom. They're laying in a CT scanner, and this is just giving you the different segments within a lobe, so to speak, within the lung, whether it's left or whether it's right. So all those colors and the top left will tell you which segment it is a part of. So there's multiple segments per lobe. The upper lobe has three segments, apical, posterior, anterior, for example. So this is more so what we'll be doing on the inside as surgeons, but just to give you just a little synopsis of how lungs are different in regards to how we treat them and how we manage them. So if you were to have a small cancer in the right upper lobe, which is on the screen there, it's circled in red, and it's small. For instance, it's less than 1 centimeter, and it did not spread to any lymph node. We would call that an early stage lung cancer, for which the survival is somewhere between 90 to 92%. For something that small, if a patient can tolerate an operation, one should be given. But there's also other ways to try to ablate that, which can also treat it. Again, surgery would be the number one modality. There's no need for chemotherapy because lymph nodes are not involved. And there would ultimately be no need for radiation if you can do it with surgery. And surgery could just remove a small segment. You don't even need to remove the entire lobe. But things change as the cancer is larger. Let's say you have a between 1 to 2 centimeter cancer. Well, you can actually still operate on this. The survival goes down a little bit, now 83 to 85%. Well, what if you're a little larger? You're between 2 and 3 centimeters. Believe it or not, we have taken lung cancer to such a great thorough understanding that we have an answer for every single size and for every single level of involvement within the chest cavity. This is what we do in clinic. We stage the patient. So this patient would still be an early stage 1 cancer with between 2 and 3 centimeters and still no lymph nodes involved. Greater than almost 4 centimeters. Now we're getting to a larger level and the survival is going down, but you see the theme here. The larger the primary cancer, the lower the survival is, but still survivable. But now we start to look at cancers that are involving some of the lymph nodes. They start moving on those highways, and you'll see the survivor is near 50%. And unfortunately, you have to say to yourself, well, when are we catching these things? Because until you get symptoms, shortness of breath, sometimes pain if it's touching the chest wall, that brings you to finding out about it. And later on, we'll talk about what some of the other modalities are to find cancer in patients who do not have symptoms, which is our strongest modality. And then this cancer is now really far towards the middle. And now we're talking about a stage 3A cancer. Why? Because it has a small cancer in one of the lobes, and one of the lymph nodes is really further along the middle of the chest, which makes it really different. And those lymph nodes, we call those N2. It's level 2 of lymph nodes. So the survival goes down. And this goes on for essentially all of the cancers, such that we're able to use kind of a mapping guideline to the exact size of the cancer, the lymph nodes that are involved, and if there's any metastasis so that we can see the stages. We're typically able to opt to offer an operation for surgery at patients who are prior to stage 3A. 3A can also receive a surgery, but usually it's specific to patients who have a few lymph nodes involved and otherwise can tolerate an operation. Otherwise, chemotherapy needs to be the modality. The jury's out because there's multiple studies that may lean on either side, but stage 3A is where you have that inflection point between, well, which direction should we go? Do we start with chemo? Do we do surgery first? Do we do chemo after surgery? There's all types of different specific nuances. And as it pertains to surgery, if you have an early cancer and the cancer has no lymph nodes, a surgery is suffice. If you have an early cancer, which does have some lymph nodes, as long as it's not stage 3A, a surgery is suffice and you will give chemotherapy because the lymph node is involved. And if you have a stage 3A, again, the jury is out. You can kind of go either way. Get them through the operation as fast as you can, as safe as you can, but they need to have chemotherapy afterwards. So aim for no complications so they can start their chemotherapy right afterwards. So this is surgery, and this is how surgery looks in a multitude of institutions. There's video-assisted thoracoscopic surgery. There's robot-assisted thoracoscopic surgery. I must tell you, as much as having a robotic program brings patients through the doors, the truth of the matter is either procedure is quite similar in that it is using essentially tools to go between the ribs to remove the wedge, as you can see on the bottom left, or the segment that is involved, or the entire lobe, and very rarely, although not infrequent, the entire lung on one side of the chest in order to get the patient to a survivable status to treat their cancer. Okay. And those entities matter on the size of cancer and the staging, of course. The larger the cancer is, the more appropriate a larger resection is in order to try to get the patient to being disease free and ultimately healed from their cancer. So the hardest part about surgery, and I'll repeat this entity towards the end as well, is actually knowing you have cancer so that you can treat the cancer. And again, this is not just for smokers. So this is surgery here, for instance. It's like a triangulation. Almost two of those arms are the left and right hand of the surgeon, and one of those arms holds the actual camera so you can see it on the screen. But we also sometimes open the incision or the cut a little larger so that you can actually do all the procedure looking directly at the tumor itself on the inside. We do that sometimes for cancers that are a little larger or when things are stuck or a little bit more complex. So who gets lung cancer surgery again? Well, those are patients who have an early stage lung cancer. Those are patients who have a good general health overall. Having good general health means not necessarily being at home on oxygen. So that might mean COPD or some lung disease at baseline, which will make them a little bit more complex because you have to remove lung to treat patients. So suffering from a lung disease that the treatment requires removing lung is not sufficient. The different types of tumors, again, it could be size, location characteristics that tells you if it should be surgery or not. Is it too close to the heart? Therefore, you can't cut the heart. So therefore, surgery probably is not the right answer. If it's involving the ribs, unfortunately, the ribs have to go as well. So there's all different elements involved. Are the lymph nodes involved? And if they are, is the patient a stage 3A or more? Is there cancer elsewhere outside of the lungs inappropriately? For instance, below the diaphragm in the adrenal glands or liver? That's a patient who may not tolerate a procedure because the cancer has gone further and other therapies need to be involved. Not to mention patient preference, fitness, and not having an advanced stage lung cancer. So when is chemotherapy appropriate? Well, there's different types of chemotherapy. Neoadjuvant, meaning before surgery. Adjuvant chemotherapy, meaning after surgery. And patients who have stage 4 lung cancer, for instance, have an advanced cancer, they shouldn't have surgery at all. They should be looking to having some type of chemotherapy or palliative modalities for people who have end stage, perhaps doing some radiation so that they can breathe better. Unfortunately, stage 4 lung cancer is quite a very strong risk of dying, but having them be comfortable in their last days, weeks, or months is important. So there are some therapies there as well. But chemotherapy, for the most part, in patients who are still able to have surgery, is typically adjuvant chemotherapy. They will get the chemotherapy after the operation because the lymph nodes are involved. And just to go over one quick scenario, if you have a patient who you ultimately do a biopsy, which is a sample of the cancer in the lung, and it's found to say, hey, this patient has a cancer, and at the time of the procedure, it is not understood that any lymph nodes are involved. You have a clinical diagnosis ultimately of being an early stage cancer. And when you do the procedure, you actually take the lymph nodes and send them out to a pathologist on every lung cancer case. And if the pathologist ultimately says this patient had involvement of one of these lymph nodes, then you now know this patient needs chemotherapy. But the surgery was still a good job because it treated the primary location, and the chemotherapy will treat the fact that it traveled. Radiation, as we discussed a little earlier, is useful for patients who have an advanced lung cancer, and perhaps treating their symptoms, preventing them from bleeding. When lung cancer travels to inappropriate areas, the radiation is helpful. What if you have a spread in multiple areas? Perhaps radiation is helpful there. If you have a situation where you do a surgery and the edge of the remaining lung inside has a little bit of cancer, which is what the pathologist will tell you when you send the cancer out during the procedure, they will tell you, hey, we see a little bit of cancer left on the edge where you cut. And if you cannot get another resection because it's not safe, it's too close to critical structures, then you'll radiate the edge of where you believe cancer will be remaining. And also sometimes when there's brain cancer from the lungs, you can also do some radiation as well. Ultimately, how can we improve lung cancer surgery outcomes? The number one thing really is having awareness, and we've tried to study lung cancer as best we could. Again, having such a high frequency of being the cancer that causes death, but unfortunately being less popular than other types of cancers, it is important that we have conversations such as these. Because the truth is, lung cancer screening is what saves lives. Lung cancer screening is important for patients, and there are some criteria. Majority use something near the ages of 55 to 80, having had a heavy smoking history. For some patients, it's 30 pack years of smoking history. So if you smoke 1 pack per day for 30 years, that's the patient who has heavy smoking history, who either are current smokers or quit in the last 15 years. They are not removed from having concerning problems that show up in the lungs. And sometimes it's in patients who've quit even longer. So it's important that we look into, well, how can we find out if someone has a problem who ultimately has no symptoms, and when they do show symptoms, it is too late. Here at Winter Haven Hospital, we are doing lung cancer. And if you have patients who have questions or concerns, feel free to reach out. But I thank you guys for your time and allowing for me to discuss some issues as it pertains to lung cancer. Thank you.
Thank you so much. I want to just steal the share just for a second because I do have that lung screening brochure that we will be sending out with the email after this. As I said in the beginning, and I know people jumped on later, please share this presentation with anyone who you might think this would be interesting, and it will be on our site in a couple of weeks so that they can watch the recorded version of it, because I do think, as Dr. Lewis said, awareness is so important. We need to make sure people know what's going on and know where they need to start having these conversations with their doctor. Screening is not for everybody, but make sure that if you are a candidate, that you're taking advantage of what you need to. So we'll make sure that this is attached to the follow-up that we have today. So I'm going to let go of that, and I'm going to stop the recording here. Give me just a second.